Good afternoon. I am back. We are about to continue. Raise your hand if you're able to hear me clearly. That's good enough. So prior to the lunch break, we completed the history portion of the patient assessment algorithm. So we are now at the secondary assessment. Now, a secondary assessment may be performed unseen. It can be done in the back of an ambulance en route to the hospital, or you might not have any time to do it based on the circumstances or the nature of the call. It just your focus can only be on ABCs. Now, it's a systematic. In the secondary assessment, it involves a systematic head-to-toe assessment. It can be systematic head-to-toe, or it can be a focus assessment based on an area of the body or a system. And you will also be collecting what we refer to as recorded vital signs. So it incorporates a systematic head-to-toe or a systematic focused assessment based on system or body part, and you're collecting your recorded vital signs. So the purpose is to perform a systematic physical examination of the patient. It may be a systematic head-to-toe secondary assessment, or an assessment that focuses on a certain area or system of the body. You will be using inspection, palpation, and auscultation. How and what to assess. So inspection, you look at the patient for abnormalities. Palpation, touch or feel the patient for abnormalities. Auscultation, you listen to sounds a body makes by using a stethoscope. And the best way to identify abnormal lung sounds is to listen with your stethoscope. We will be using the DCAP BTLS again, but we're going to be going a little bit slow in the secondary assessment. So the purpose of the secondary assessment is to identify problems or injuries that may have been overlooked or developed slowly. Right? So it is to identify problems or injuries that may have been overlooked or they develop slowly. Compare findings on one side of the body with the other side when possible. Systematically assess the patient. The goal is to identify hidden injuries or identify causes missed during the 60 to 90-second exam during your primary assessment. Now, your focus assessment performed on patients who have sustained non-significant MOIs or unresponsive medical patient. Very important statement to commit to memory, to commit to muscle. So when we're going to do a focus assessment, it is done for your trauma patients with non-significant MOIs, and it is done for medical patients who can communicate with you. Typically based on the chief complaint. The goal is to focus your attention on the body part or systems affected by the priority problems. Now, each system well, not all the system in the body, but the main systems, there is an approach to assess each of these systems. Now with the respiratory system, you expose the patient's chest, you look for signs of airway obstruction, you inspect for symmetry, so the right side of the chest must move the same time as the left, you listen for breath sounds, and as EMTs, we use apex, anterior, mid-axillary, fifth intercostal space for the base of the lungs, left and right, and at the back it is apex and base. So it's 4 points for the EMTs. If you watch videos where they use more than 4 points, that's fine. So I don't have a problem with that. If you want to use more than the 4-point auscultation, that is perfectly fine. But as an EMT, all I'll be testing for is the 4 points: apex, mid-axillary, left and right base, posterior, apex, and base. That's it. If you do more than that and you know where you put in your stats, then you get extra mark for that. But we need to listen. It's important to listen to a patient's lung sounds, because when you listen, that is going to tell you if your patient needs more than oxygen. So that's the purpose of listening for lung sounds. So it means that I should know if I'm giving a patient high or low flow oxygen before I listen to the lungs. Because the purpose of me listening is to determine if my patient is going to require more than oxygen. So listening to lung sounds is extremely important. Anterior, your mid-axillary points, and your posterior, the thorough. So I've said that before. Listen to breath sounds, measure the respiratory rate, look for retractions, and increase work of breathing. So your assessment for the respiratory system will center around rate, rhythm, quality, and depth. We know this by now. So the respiratory rate, a normal rate in adults ranges from 12 to 20 breaths per minute. For the pediatric population, it's going to be much faster. Count the number of breaths in 30 seconds and multiply that by 2. If the patient has an irregular breathing pattern, you do it for a full minute. The patient should not be talking when you're doing your breathing rate. That can alter the rate. So once we have obtained the rate, next we will look at the rhythm. That is the consistency. Regular, is it regular or irregular? Regular, the time from one peak chest rise to the next is fairly consistent. Irregular, the respirations vary or the rate changes frequently. And if a patient has an irregular breathing pattern, or is breathing very slow, or is breathing very shallow, then you're looking at a patient that is going to require positive pressure ventilation because they're in respiratory failure. So it's rate, rhythm, quality. Quality has to do with whether or not there is muscle use, abnormal lung sounds with or without auscultation, and is it positional. So quality of breathing, normal breathing is silent. Breathing accompanied by other sounds may indicate a significant respiratory problem. The depth of breathing is whether or not you can see visible chest rise. So that's the amount of air the patient exchanges. It depends on the rate and tidal volume. We cannot measure tidal volume in the field, so we're looking at whether or not we can see adequate chest rise bilaterally. And the best place for us to listen for breath sounds is posterior. So there's less surface area around there. You'll be able to hear the lung sounds clearer at the back. Don't omit your posterior lung sounds. Very important. Right? So you have your APCs, right and left. APCs are the lungs, and then mid-axillary, fifth intercostal space. On this side, opposite side at the back. And if they're sitting down, you let them cross the arms over the legs to move the scapula out of the way. Once you're able to do that, you have better access to the apex. So we want the apex and base at the lungs at the back. Now, what are you listening for? Normal breath sounds. Snoring breath sounds, we know what that means. So snoring is the tongue. Wheezing breath sounds, we know what that means at this point. That means there is bronchiole. The bronchioles are constricted. So that's lower airway constriction or bronchospasm. Crackles can be rhonchi or rales. So rhonchi or rales is actually crackles. You have two types of crackles. You have coarse crackles and you have fine crackles. Crackles mean there is fluid inside of the alveoli. If a patient has fluid inside of the alveoli, they cannot get good oxygenation. Sorry, they cannot get good respiration. So rhonchi is fluid. The difference is rhonchi is what is referred to as fine crackles. It's not coarse. So rhonchi is thick fluid in the alveoli, so it's more pus-like. It's gonna be present in patients with lung infection. The coarse crackles, which is the louder one, is gonna be more common with patients in congestive heart failure or patients who have been exposed to chemicals who develop pulmonary edema, or patients who are in certain types of shock. Stridor is a high-pitch whistling type wheezing sound that is heard without a stethoscope. So you don't necessarily need to put a stethoscope on your patient to hear stridor. It is an indication of upper airway obstruction. And I think I have some videos of that on my laptop. I don't know if I'll be able to find it today, but I'll try and find it that you can listen to some of these sounds. So these are your sounds. And we know, and we are familiar with what gurgling and bubbling sounds indicate. Hold on a second. Sorry about that. Background was getting a bit noisy. So that's the respiratory system. Let's look at the cardiovascular system. So for the cardiovascular system assessment, look for trauma to the chest and listen for breath sounds, because cardiovascular system is closely connected to the respiratory. You don't assess one without the other. Consider the pulse, the respiratory rate, and the blood pressure. Pay attention to the rate, quality, and rhythm of the pulse. Consider your findings when assessing the skin. Check and compare your distal pulses. Consider auscultation for an abnormal heart sound or sounds. Pulse rate. Normal resting rate for an adult is between 60 to 100 beats per minute. The younger the patient, the faster the pulse rate is going to be. So we will look at the quality of the pulse. Can be described as stronger than normal, which is a bounding pulse. Can be a pulse that is weak and difficult to feel. This is described as weak and or thready. Pulse rhythm, so rate, quality, and strength. So quality and strength are the same, really. You can use them interchangeably. Rate, so it can be rate, quality, and rhythm, or it can be rate, rhythm, strength, whichever you're comfortable with. The pulse rhythm, again, we're looking at consistency. So is it regular or irregular? The interval between each contraction should be the same. The pulse should occur at a constant regular rhythm. Irregular, if the heart periodically has an early or late beat, if a pulse beat is missed. And if a patient has a pulse that is irregular, this is a red flag. Something is not quite right with that patient's heart rhythm. Something is abnormal about that heart rhythm. Now with the blood pressure, the pressure of circulating blood against the walls of the arteries, a drop in blood pressure may indicate a loss of body fluid or blood, can be a loss of vascular tone, meaning the blood vessels are too dilated, or it can be the arterial side is too constricted, or it can be the pump has a problem. Decreased blood pressure is a late sign of shock. Abnormally high blood pressure may result in a rupture or other critical damage to the arterial system. Can develop if the blood pressure is constantly high. Over time, it can develop a weak area in the walls of the artery, or it can start to split the walls of the artery in two. Not going to go through how we would obtain a blood pressure. That's practical, right? But you have your digital equipment and you have your manual BP cuff. We will be practicing with the manual BP cuff, but most agents, have some form of digital available, whether it's a cardiac monitor that you're using that has the capabilities to do vital signs, or you just have a digital cuff available. I am not a fan of digital equipment, but I mean, as we progress in EMS, most things are going to be digital. So what I practice to do is I will use my cardiac monitor to get my appropriate vital signs. But if I get a blood pressure that seems a bit off, doesn't seem quite right, then I will either ask my partner to do it manually or I will do it myself manually. Now, the method that we use to obtain a blood pressure in the field is the combination of the auscultation and palpation method. So we use a combination of auscultation and palpation. Auscultation is the most common means of measuring blood pressure. Palpation method does not depend on the ability to hear sounds. And back in the past, we used to use the palpation method if we're in an environment that is very noisy, where we can't hear properly. The palpation method doesn't give you an exact blood pressure reading, and it can only give you a systolic blood pressure. So it can only give you the top number. And it's really an estimation. But as EMS progressed over the years, we learned to combine both. So we use the palpation to find a range, and then we use the auscultation to get the exact reading. We will go through all of that in skills. Normal blood pressure. Hypertension is a blood pressure that is lower than normal. Hypertension is a blood pressure that is higher than normal. And we have some range on that chart. Not something that is a must. These numbers are things that you will become more familiar with when you have your protocols or what we call cheat sheets, because it's very difficult to remember a lot of numbers if it's something that you're not doing on a regular basis. So we use a lot of cheat sheets or protocols to remind us of certain ranges. Definitely you need to be familiar with your adult range or any range in which you're going to see a large portion of those persons in your population that you're providing service for. Right? So that's circulation or cardiovascular system assessment. Now the neurologic system. And I hope you realize that we keep coming back to the core systems that we covered in anatomy and physiology. Neurologic assessment should be performed with any patient who has changes in their mental status. And remember what that means. So a change in mental status means that the patient is not correctly responding to person, place, time, and event. A patient with a possible head injury, stupor, dizziness, drowsiness, and syncope. You need to evaluate the patient's level of consciousness and orientation to person, place, time, and event. You will use the AVPU scale if appropriate, and we know this by now. And we will use the Glasgow Coma scale, which is more universally accepted. The Glasgow Coma scale look at 3 areas: eye opening, verbal response, and motor response. So it's EVM. They can get a maximum of 4 for eye opening, 5 for verbal, and 6 for motor response. So a total would be 15. Any number below 8 with associated signs and symptoms is going to be a patient that you need to focus heavily on their airway. So the GCS or Glasgow Coma scale. The pupil is a black center portion of the eye. The pupils are normally round, of approximately equal size, and in the absence of any light, the pupils will become fully relaxed and dilated. So when we shine a light in the pupil, it means the pupil will constrict. When we move that light, the pupils dilate. Now, what does this mean? So you can shine a light in the pupil and it looks pinpoint or constricted. You can shine a light in the pupil and they look fixed and dilated or dilated. Can shine a light in the pupils and they look uneven or unequal. Now, if you shine a light in the pupil and you're seeing unequal pupils, this can be an indication of a head injury or stroke, or it can be that the patient was born this way. So the patient actually born with unequal pupils or anisocoria, as it's called. You can have a patient with pinpoint pupils less than 3 millimeters in size. So when you shine the pen light in the pupil, you're seeing pinpoint pupils less than 3 millimeters. This is an indication of what we would classify as a opiate or opioid overdose. So these are powerful pain medication with narcotic effects. In other words, they depress the brain function. So opiates and opioids depress the brain function, and that can affect the patient's ability to breathe, and it can lead to death. So we're talking about heroin, morphine, fentanyl, Dilaudid, OxyContin, oxycodone. These are opiates or opioid type medication. And that is something that you will see in patients that overdose on these meds. You can have the pinpoint pupil history of drug abuse specific to that type of medication or drugs, and they're having significant respiratory problems, right? And they will go into respiratory failure and arrest very quickly if it cannot be reversed. It is very common in the United States. It's one of the most significant problems they're having currently because they tend to over-medicate their population. So persons get addicted to these drugs very easily. Now with the dilated pupils, if it's fixed and dilated, it can be a sign of death, right? So it can be considered a sign of death. If the patient is still talking to you with the pupils looking like that, can also be that they're having certain type of contact lenses, or it can be the patient overdose on barbiturates, which are seizure type meds. So a small number of the population exhibit unequal pupils, which is anisocoria. Causes of depressed brain function. So injury of the brain or brainstem can cause the pupils to become unequal. Trauma or stroke can cause it. Brain tumor, inadequate oxygenation or perfusion, drugs or toxin. Right? These are things that can cause the pupils to change. But once you see unequal pupils, the first thing you want to think about is injury to the brain or stroke until you can determine whether or not it is natural for the patient. That is what you should be thinking about in worst case. Now, we describe the pupils using the acronym PEARL. So P-E-R-R-L, PEARL. So there are quite a few acronyms that you need to learn over the length of this course. I've covered quite a few so far. So the P is pupils, E is equal, the A represents and, the first R is round, the other R is regular in size, and the L react to light. And the pupils work together. So if you shine a light in the right pupil, when the right pupil constrict, the left pupil must constrict at the same time because they work together. The nerves work in pairs. Now, neurovascular status, and this is sometimes confusing for students. So there are quite a few things that we have to look at when we're assessing the nervous system. We need to consider the patient's level of consciousness. We need to look at the GCS, eye opening, verbal response, motor response. We need to check the pupils for pupil reaction, and we need to do a neurovascular assessment. Now, a neurovascular assessment is done to determine if a patient has complications from a spinal injury, has complications from a fracture or a dislocation to a limb, and to determine if a patient has complications from a stroke. So it is used to identify complications with spinal injury, complications with a fracture or joint injury, and complications from a stroke. Now, what a neurologic assessment, neurovascular assessment is, you are looking at the sensory nerve, you're looking at the motor nerve, and you're looking at circulation to the area. So when we're checking the neurovascular status, we check the distal circulation, and when we're checking distal circulation at this point, it's not the same as circulation in your primary assessment. So when we're checking distal circulation at this time, is really to check to see if a pulse is present. Does it feel strong or weak? That's it. Is there still blood flow in the area? Does it feel strong and weak or weak? That's it. Because you would have known the pulse rate within the body prior to getting to that point. So we don't need to do it again in our limb. We already did it in the primary assessment, and that's where we will continue to do it when we're doing our reassessment. So when we're doing the neurovascular, it's to determine if circulation is still going to the area. Does it feel strong? Does it feel weak? So that's one. The sensory nerve is being evaluated to determine if signals is moving from the limb to the brain. And the motor nerve is being evaluated to determine if signals are coming from the brain to the limb. So that is what is referred to as a neurovascular assessment. Now, anatomic regions, the head, neck, cervical spine. We will palpate the scalp and skull. We will check the patient's eyes. We will check the color of the sclera. We will assess the patient's cheekbones. We will check the patient's ears and nose for fluid. We will check the upper and lower jaw. We will check inside the mouth for broken or missing teeth. We will note any unusual odors coming from the mouth. For the chest, inspect, visualize, and palpate. Watch for both sides of the chest to rise and fall together with normal breathing. Observe for abnormal breathing signs. And when we get to the abdomen, we will observe the abdomen. So we look at the abdomen. Is there any abnormal pulsation present? If you see any pulsations in the abdomen, do not trouble it. So observe the abdomen, palpate for tenderness, rigidity, and patient guarding. And we will go quadrant by quadrant, and we always compare left to right. So it's left to right, always bilateral. It's not left upper quadrant and then left lower quadrant. It's left upper quadrant, right upper quadrant. So you always compare left to right. For the pelvis, when we get to the pelvis, we do not rock. We do not rock the pelvis. We will push in on the side of the pelvis, not too forcefully, and then we will push down. And we need to observe for priapism in the male population, and that is a painful erection that is associated with spinal injuries. When we get to the extremities, inspect for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate for deformities, check for pulse, motor, and sensory function. And that once we're checking pulse, motor, and sensory, that's a neurovascular assessment. So everything that we did anterior, we have to do it posterior. So we need to log roll that patient and check the posterior. So we inspect the back for decap, PTLS, symmetry, and open wound. We palpate the spine from the neck to the pelvis for tenderness and deformity. Now, when you log roll a patient, it is a good time for you to listen to the posterior if you didn't get that chance earlier. Now, apart from doing your systematic assessment or your head to toe in your secondary, we need to start utilizing our diagnostic tools and get our recorded vital signs. And at this point, we're going to repeat things that we would have already checked. And when I say repeat, so if you already did a respiratory rate or a pulse rate, you're going to do it again. Repeat things that you have already checked before, because we need to identify trends. You need to be able to determine if your patient is trending up or trending down. Use appropriate monitoring devices. Should never replace your comprehensive assessment of the patient. The pulse oximetry measures the concentration of oxygen in the capillaries. It also gives you a pulse rate, so don't get in the habit of putting on your pulse ox, write down the pulse ox reading and write down the pulse. You need to check the pulse manually to see if it matches the pulse ox reading. Don't get in the habit of treating your equipment. You treat your patient, not equipments. So the pulse oximetry measures the oxygen saturation of the hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. We can also obtain capnography. Now, capnography is not something that I've seen used a lot in Jamaica. I'm not even sure if I've seen it a lot in the hospital setting, but it is a very useful tool to determine if your patient is ventilating properly, if they have good circulation, or if they're metabolizing properly. And basically what capnography does, it gives a waveform and it gives digital values that represents the amount of carbon dioxide that is coming out of the patient. And the normal range for capnography is 35 to 45 millimeters of mercury. If the capnography reading starts to drop below 35, your patient is breathing too fast. If the capnography reading starts to go above 45 millimeters of mercury, your patient is breathing too slow. Once a patient is breathing too slow, the patient is at risk for respiratory acidosis, which can cause significant damage to brain cells. We can check blood glucometry, which measures the level of glucose in the bloodstream. It is an EMT skill. You need to be familiar with the glucometer machine that your organization uses. In the States, they tend to use the milligrams per deciliter reading. So it's 80 to 120 milligrams per deciliter. That's normal. Some books will have 70. In Jamaica, we use the millimoles per liter. Now, it's fairly straightforward. If you have milligrams and you want to convert that to millimoles, you divide by 18. If you have millimoles and you want to convert that to milligrams, you multiply by 18. Blood pressure, not going to talk about that. All right, now the final area of the patient assessment is your reassessment. But before we get to that, let's just recap real quick. The secondary assessment is necessary to pick up things that may have been overlooked because we were focused on the primary assessment. It incorporates a detail head to toe. You might not get the opportunity to do that all the time based on the nature of the emergencies. It also incorporates you doing a focus assessment on a body part or system that is affected, and you will be doing your recorded vital signs at this point, and it should include things you already check. So when you're doing your vital signs, you want the patient's level of consciousness. You're going to consider that. You're going to consider the pupil reaction. You're going to be checking the respiration, the pulse, and once you're checking respiration, you want pulse oximetry and capnography if that's available. You're checking the pulse rate, and you want your blood pressure, and you can do your GMR as well. So these are the vital signs you should always be thinking about. So when we start to practice, these are the vital signs you will ask for. Consider the patient's level of consciousness, pupil reaction, respiration, pulse oximetry, capnography if available. If available, you will obtain your GMR if it's necessary and your blood pressure. And then you compare that to what the patient's initial findings are, because the vital signs that you're obtaining now is after you have administered treatment. So what was it before you started treatment? What is it now? So we want that comparison. And ideally, you want 3 sets of vital signs. So that's your goal. Might not happen all the time, but that's your goal. You want 3 sets of vital signs. All right, now the reassessment, this is the final segment of the patient assessment algorithm, and it's the easiest section of the algorithm. What you need to understand at this stage is you're going to repeat your primary assessment. So when we're doing a reassessment, it is a repeat of the primary assessment. So you're going to look at the patient's level of consciousness again, reevaluate airway, breathing, circulation. Our goal at this point is to determine if the patient is improving. Is the patient getting worse? Is there some treatment I need to offer now that has not been offered before? And do I need to downgrade treatment? What are the vital signs telling me? So you're repeating your primary assessment, you're repeating your vital signs, you're looking to see if your patient improve, you're looking at your trends. Is he trending up? Is he or her trending up or down? And during this phase, you will do your documentation as well. So reassess the chief complaint, ask and answer the following questions. Is the current treatment improving the patient's condition? Has an already identified problem gotten better? Has an already identified problem gotten worse? What is the nature of any newly identified problems? So recheck your interventions. Check all your interventions at this point. Most important are the patient's ABCs, ensure management of bleeding, ensure adequacy of other interventions, and consider the need for new interventions. Identify and treat changes in the patient's condition, and you will document at this time. And yeah, there are different methods of documentation. You have the SOAP method, you have the chart method, you have chronological order. Your organization will determine which method you use. I am personally a fan of the chart method, so that's the one I prefer. And yeah, that's the one I'm comfortable with. But I am aware of the SOAP method and chronological order. Chronological order mean you're writing about the event from the beginning to the end. The chart method or chart acronym, which is CHXARXT. The C is chief complaint. The H represents history. HX is history. The A is assessment. So what has your assessment reveal? And RX, that with the large R with a small X, that's treatment in medicine, shorthand. So the RX would represent what was the treatment provided, and the T is method of transportation. How did you transport this patient? The SOAP acronym, SOAP, the S is subjective information, the O is objective information, the A is assessment, and the P is plan. There you have your chronological order. And during this time, you may be required to give a report over the radio, and it's going to be based on what the patient told you. So what did the patient tell you? What did you observe? What did you do based on your observation? And how did the patient respond to that? And your method of transportation, are you using lights and sirens, non-emergency transport, only lights, stuff like that. If your patient is a critical patient, every 5 minutes, you will repeat your primary assessment. So if your patient is critical, you need to reevaluate your primary assessment every 5 minutes, right? So reevaluate that ABCs. If the patient is stable, every 15 minutes is acceptable. Once your patient is critical, you continually monitor your patient. And that would be the end of the patient assessment chapter. So it's a long chapter. I believe it's the longest chapter in your textbook. I might be wrong. I think airway management competes with it pretty closely, but I think it's longer than airway management. It's a very long chapter, and it's a very important chapter because it will form the foundation of your skills. Are there any questions at this point?